Welcome everyone. This class is on immunological emergencies and covers the medical component of the NCCP model for your research hours. Our objectives are simple in this class. We want to cover what the body does in response to an allergen, what's the difference between a localized allergic reaction and an anaphylactic reaction. We will explain how medications work and what the treatment of these emergencies are. There's also a skills assessment at the end that you will cover on your own. All right, let's talk about allergic reactions. One of the most common medical emergencies you can see in the field. Allergic reactions range from mild, localized responses to severe, life-threatening anaphylaxis. Understanding where your patient falls on that spectrum helps you treat effectively and prevent escalation. An allergic reaction is your immune system overreacting to something that's normally harmless. Things such as pollen, an insect sting, or certain foods. The body identifies that allergen as a threat and launches an unnecessary defense response. Most of us have things like seasonal allergies where we get itchy eyes or a runny nose. That's the immune system reacting to the environment and trying to provide defense. Another example is an insect bite or sting that caused redness, maybe a little swelling where it occurred, and an itchy feeling. This is a localized response because it is just localized at the spot of the irritation. When the immune system reacts, cells called mast cells release histamine, which causes blood vessels to dilate and leak fluids into tissues. That's what leads to swelling, redness, and itching. Histamine equals inflammation and fluid leakage. Think of it as the body's chemical alarm system. With a localized reaction, you'll see things like redness, swelling, hives, and itching. An example is you might see a bee sting with a 3-inch red swollen area that's itchy but no airway involvement. That's what we consider localized. Sometimes the reaction includes mild nausea, vomiting, and maybe even diarrhea. This happens because the same inflammatory chemicals that affect the GI tract too. A question for everybody is, why do you think the digestive system is involved in skin reaction? The answer is histamine affects multiple organ systems, and we'll cover that in just a second. Localized allergic reactions usually only need supportive care. Remove the allergens, such as a stinger. We do not treat local allergic reactions, but we can encourage a patient to maybe apply a cool compress, possibly take an oral antihistamine or over-the-counter steroid creams, and they can consult with their doctor. We never just blow these patients off, though. We need to always monitor these patients closely. A localized reaction can quickly progress, especially with repeat exposures. The immune system remembers allergens. The first exposure builds sensitivity. The second can cause a massive system-wide reaction, what we call anaphylaxis. That's why a patient may be fine after one sting, but go into anaphylaxis after another. An example is a person that gets stung by a bee last summer, had a small red bump. This summer, the same sting causes throat tightness, hives everywhere. We want to watch out for that. So to wrap it up, the key takeaway is that a localized reaction is usually mild, but it's a warning sign. If the patient's body sees the same allergen again, the reaction could escalate into a full-blown emergency. That's why documentation and patient education matter. Note the allergen, advise follow-up, and stress the importance of carrying an EpiPen if that's something that's indicated. Now that we've covered mild allergic reactions, let's talk about when things go wrong, really wrong. Anaphylaxis isn't just a bad allergic reaction, it's a full-body, life-threatening immune response that can kill within minutes if untreated. Unlike a simple allergic reaction that's localized, anaphylaxis affects multiple organ systems, such as the skin, respiratory, cardiovascular, and gastrointestinal. That's why you'll see hives and airway swelling and low blood pressure all at once. Anaphylaxis is the immune system going into overdrive, a massive systemic release of inflammatory chemicals in response to an allergen. The body's own defense system starts to shut down vital functions like breathing and circulation. An example is a patient with a peanut allergy that accidentally eats something cooked in peanut oil. Within minutes, they develop hives, swelling, have trouble breathing, and collapse. During anaphylaxis, huge amounts of histamine and other mediators are released all at once. That histamine causes blood vessels to dilate, leak fluid, and tissues to swell throughout the body. This chemical flood explains the sudden drop in blood pressure and airway swelling you'll see. Airway swelling includes face, lips, tongue, neck, and things like the face. Those dilated vessels and leaky capillaries cause fluid to shift out of circulation, leading to hypotension. The blood pressure crash is what we call anaphylactic shock. As fluid leaves the bloodstream, the heart has less volume to pump and perfusion drops. That's why the skin turns pale, cool, and clammy. The body can't maintain pressure or circulation. At the same time, histamine causes the bronchi to constrict and mucus glands to produce, clogging the airways. The patient struggles to move air. You may hear wheezing or stridor. An example is a patient says, "I can't breathe," and you hear high-pitched inspiratory sounds. That's the airway narrowing from bronchoconstriction and mucus. If airway swelling and bronchoconstriction continue unchecked, oxygen can't reach the lungs or bloodstream, leading to respiratory failure. You'll often see swelling of the lips, tongue, or throat. That's what we call angioedema. It can rapidly close off the airway if not treated. The most immediate threat in anaphylaxis is airway obstruction. That is why epinephrine is our first line treatment. It reverses both airway swelling and vascular dilation. This might be a hard thing to wrap your mind around. I've seen this on calls where the provider wants to go for albuterol because this fixes the breathing, right? But the answer is epi in this situation, and it should be our first thought. Then we can think of albuterol, then we can think of Benadryl and steroids. Anaphylaxis is a race against time. The body's immune system is attacking itself, and only rapid intervention with epinephrine, oxygen, airway management, and transport can stop it. Remember that treat it early and aggressively. Mild reactions you can monitor. Anaphylaxis, you must act immediately. We've talked about what anaphylaxis looks like. Now let's discuss what you do about it. This is a true life-threatening emergency. The faster we intervene, the better the outcome. Remember that airway, breathing, circulation are your top priorities. The first and most important step is to secure the airway and ensure oxygen can move in and out. If the airway is compromised by swelling or bronchoconstriction, your patient can deteriorate quickly. Be ready to use airway adjuncts and assist ventilations as needed. Have your BVM, suction, airway kit at the ready. If swelling progresses, you may need advanced airway intervention en route to the hospital. If the patient's oxygen saturation drops below 94%, apply oxygen immediately. Start with a non-rebreather mask, 15 liters per minute, and titrate to maintain saturations above 94%. Oxygen supports perfusion and helps counteract hypoxia from bronchoconstriction and airway edema. An example is you have a 25-year-old with facial swelling, some hives, and their SpO2 is 90%. What do? We apply high-flow O2 immediately while we're preparing the epinephrine. Epinephrine is the cornerstone of anaphylaxis treatment. If the patient carries an auto-injector, assist them in self-administration, or if you're an EMT IV, then you can draw up and administer our Epi 1-to-1 IM per our protocol. Use the mid-outer thigh, what we call the lateral aspect, and administer there. Epinephrine works fast. It reverses bronchoconstriction, reduces airway swelling, and raises blood pressure by constricting blood vessels. Never hesitate to give epinephrine when in doubt. Delaying it increases mortality. So then you can demonstrate how to use an auto-injector. It's easy to use. You just remove the safety cap, place it against the outer thigh, hold it down for 3 seconds, and then massage the area after the administration. Even if the patient improves after epinephrine, they are not out of danger. Reactions can reoccur hours later, and this is something that we call biphasic anaphylaxis. Transport all anaphylaxis patients to an emergency department for observation and further treatment. Our job doesn't stop when the patient looks better. Monitor airway, vitals, and mental status continuously during transport. Early recognition, early epinephrine, and early transport saves lives. Now you have the opportunity to demonstrate how to use an auto-injector, or if you don't have one available, then just go ahead and draw up Epi and administer it per our protocol. I'd like to encourage everyone to review the allergy anaphylaxis protocol in addition to the epinephrine protocol. so that you're ready to act quickly when the time comes. Thank you, everyone. Have fun.